Welcome to your personalized deep dive. This time, it's into vascular surgery. We're going on a journey through medical student notes from Gulf Medical University in the United Arab Emirates. It's like a cheat sheet for future surgeons. I don't know about you, but I find it fascinating to peek into this kind of material. It's not every day you get to learn, straight from the source, what doctors in training are expected to know.
Yeah, that's like the high-yield facts,
Yeah.
the must-knows for those grueling exams. And believe me, there's a lot to cover when it comes to the vascular system.
So let's map out our route. We'll start by exploring the big picture of arterial diseases, those conditions that affect the arteries, the vessels that are responsible for carrying oxygen-rich blood away from the heart.
Exactly, and at the heart of so many of these conditions is ischemia, which essentially means starved of blood. It's all about an inadequate blood supply reaching the tissues. Now, ischemia can be acute, like a sudden roadblock cutting off traffic, or chronic, like a gradually worsening traffic jam.
So imagine a crucial delivery truck trying to reach its destination, but there's a problem on the route. That's kind of what's happening with ischemia, right?
That's a great analogy.
Yeah.
And just like with those delivery trucks, the severity of the problem depends on a few things. Which road, or in this case, which artery is affected, how quickly that blockage happens, and the overall state of the vehicle, the patient's health.
So someone with a pre-existing heart condition would be like a truck with a sputtering engine. They're already struggling, and any further disruption is a bigger deal.
Precisely. Their body is already working overtime to keep blood flowing. So any compromise to their circulation can have a more dramatic impact.
Makes perfect sense. Now, before we delve into specific conditions, can you give us a simplified roadmap of the major arteries in the legs? I mean, we need to know the key players in this intricate network.
Think of it like this. The aorta, the main artery leaving the heart, that's the big highway. As it travels down, it branches into the iliac arteries, which further divide into the femoral arteries, supplying blood to the thighs. The femoral artery continues down, eventually becoming the popliteal artery behind the knee, and finally branches into the tibial arteries, which nourish the lower leg and foot.
So it's a branching network like a tree, with each smaller branch delivering blood to a specific area. And any blockage or disruption along this network can have significant consequences.
Exactly. Now imagine one of those crucial roads suddenly getting shut down completely. That's what happens in acute limb ischemia, a true vascular emergency.
Okay, this sounds serious. Walk me through it. What exactly is going on in acute limb ischemia?
It's a sudden and complete blockage of arterial blood flow to a limb, often caused by an embolism. Picture a blood clot, like a rogue piece of debris, traveling through the bloodstream until it gets lodged in a smaller artery, cutting off circulation downstream.
Like a dam suddenly forming in a river, backing up everything behind it.
That's a great way to visualize it. And one of those common culprits behind these rogue clots is atrial fibrillation, a heart rhythm disorder that can cause blood to pool in the heart's upper chambers, increasing the risk of clot formation.
So if someone has atrial fibrillation or other heart conditions, they should be extra vigilant about any sudden changes in their limbs.
Absolutely. Time is of the essence with acute limb ischemia. Think of it like this. Skeletal muscles are like high-performance engines. They need a constant supply of oxygen-rich blood to function properly. They can only tolerate about 6 hours of ischemia before irreversible damage sets in.
6 hours. Wow, that's a tight window. Are there any other causes of this sudden blockage besides those rogue clots?
Yes, definitely. Sometimes a clot can form directly within the artery, a process called thrombosis. This often happens due to a ruptured atheromatous plaque. Think of it like a crack in the pavement of the artery wall, creating a rough surface where clots can easily form. And then there's trauma, like a direct injury to the limb. That can disrupt blood flow as well. You'd be surprised how often we see this in patients with injuries around the knee, potentially affecting the popliteal artery, or even around the elbow, impacting the brachial artery.
It's fascinating and a little frightening to think how vulnerable these blood vessels can be. Now let's say someone has one of these causes. What are the warning signs they should be looking out for? How would they know they need to rush to the hospital?
There's a classic set of symptoms. Doctors call the 6 Ps: pain, pulselessness, pallor paralysis, paresthesia, and poikilothermia.
6 Ps. That's a lot to remember. Let's break them down. Pain and lack of a pulse in the affected limb seem pretty self-explanatory, but what about pallor?
Pallor simply means the affected limb will look paler than usual. Due to the lack of blood flow, it's as if the life is being drained out of it.
Okay, that makes sense. And paralysis or weakness is a sign that the muscles aren't getting the oxygen they need to function. What about paresthesia? That's a new one for me.
Paresthesia is an abnormal sensation, like tingling numbness or pins and needles, caused by those oxygen-deprived nerves, sending out confused signals. And finally, there's poikilothermia.
Poikilothermia. That one sounds almost reptilian.
It's actually a simple concept. Poikilothermia just means coldness. The affected limb will feel noticeably colder than the other one, because the warm blood isn't reaching it.
Okay, so if you experience any combination of those 6Ps, especially if you have a known risk factor like atrial fibrillation, it's time to seek medical attention immediately, right?
Absolutely. Prompt diagnosis and treatment are crucial. Doctors will use tools like Doppler ultrasound, which is like a sonar for blood vessels to assess blood flow. They might also do an ECG to check heart rhythm and an echocardiogram to visualize the heart's structure and function. Treatment might involve medications to prevent further clotting, or even a fascinating procedure using a Fogarty balloon catheter to physically remove the blockage.
A balloon catheter. I'm picturing a tiny hot air balloon floating through the bloodstream. Tell me more about that.
It's not quite a hot air balloon, but it's an ingenious device nonetheless. They insert this thin catheter through an artery, navigate it to the site of the blockage, and then inflate a tiny balloon at the tip. This helps dislodge the clot and restore blood flow.
That's incredible. It's like a miniature plumbing job inside the body. But I'm wondering, are there any risks associated with restoring blood flow so quickly?
You're right to ask that. There is a potential complication called compartment syndrome. When blood flows cut off, the muscles and tissues can swell within their tight compartments, like overfilling a container. Restoring blood flow too quickly can worsen the swelling, leading to further damage. So careful monitoring of the affected limb after reperfusion is crucial.
So it's a delicate balance. You need to restore blood flow, but you have to do it in a controlled way to avoid further complications.
Fascinating. Okay, so we've covered acute limb ischemia, a true medical emergency. But what about chronic arterial ischemia, the slower, more insidious form of this condition? What makes it different?
With chronic ischemia, the blockage develops gradually, like a slow leak that eventually weakens the foundation. This gives the body time to try and compensate by building alternative routes for blood flow, a process called collateral circulation.
So the body's basically trying to reroute the blood, like creating detours around a road closure.
Exactly. But those detours aren't as efficient as the original route, so symptoms will still eventually appear as the blockage worsens. And this is where atherosclerosis comes in, right? A buildup of plaque in the arteries that we talked about earlier.
I got it. Atherosclerosis is like the rust and corrosion that slowly builds up inside those arterial pipes, narrowing them and making it harder for blood to flow through. And it's linked to those lifestyle factors we often hear about: smoking, diabetes, high blood pressure, high cholesterol, and lack of exercise.
So it's a condition that often develops over years, and in many cases it's preventable through healthy lifestyle choices.
Precisely. Now, one of the hallmark symptoms of chronic arterial ischemia is intermittent claudication.
Intermittent claudication. That one sounds a little intimidating. What does it feel like?
It's basically pain in the muscles, typically in the legs, that comes on during exertion and is relieved by rest. Imagine you're walking and your calf muscles start cramping, forcing you to stop. That's claudication. It's like your muscles are sending you a signal: hey, we're not getting enough blood down here.
So it's a pain that's directly related to activity, and it goes away when you rest.
Exactly. And what's fascinating is that the location of the pain can often give clues about which artery is affected.
Really, it's like a built-in diagnostic tool. Tell me more about that.
For example, if the blockage is in the iliac arteries higher up in the leg, you might experience pain in the buttocks and thighs. Blockage in the femoral artery often leads to calf pain. And if the popliteal artery is involved, you'll likely feel the pain in your feet.
Wow, so just by paying attention to the location of the pain, you can get an idea of where the problem might be. That's incredible.
It is. And understanding how claudication impacts your daily life is also important. Can you walk as far as you used to? Does it affect your job or hobbies? This helps doctors determine the severity of the condition and guide treatment decisions.
Okay, so claudication is the pain that comes with exertion, but what about rest pain? That seems a little counterintuitive. Why would your legs hurt more when you're resting?
Rest pain is a sign of critical limb ischemia, meaning the blood supply is severely compromised. And ironically, it often worsens when you lie down and improves when you hang your legs over the bed.
Wait, why would it hurt more when you're lying down? That doesn't make sense.
Think of it like this. When you're lying flat, gravity isn't helping to pull blood down to your legs, so those already starved tissues are getting even less blood, intensifying the pain. But when you dangle your legs, gravity lends a helping hand, allowing more blood to reach those tissues and easing the discomfort.
Wow, that's a wild concept. It's like your body is waging a constant battle against gravity to keep those tissues alive.
Exactly. And in severe cases, chronic ischemia can lead to other complications, like ischemic ulcers.
Ulcers, those don't sound pleasant.
They're not. Ischemic ulcers are incredibly painful sores that typically develop on the feet, toes, or lower legs. Imagine a small cut or blister that just won't heal. Because there's not enough blood flow to the area, it can progress to a deep open wound that's incredibly difficult to treat.
So it's like the body's ability to repair itself is compromised due to the lack of blood flow?
Precisely. We'll contrast these with venous ulcers later, which have a different appearance and a different set of causes.
Okay, so we've covered a lot of ground with arterial diseases, but I know there's a whole other world of potential problems lurking in the aorta, the main artery carrying blood from the heart. Let's talk about aneurysms. They always sound so dangerous, and I'm not even sure I understand what they are.
Aneurysms are indeed a silent threat, often lurking undetected until they cause serious trouble.
Okay, I'm all ears. Demystify these ticking time bombs for me. What exactly is an aneurysm?
In essence, an aneurysm is a localized dilation of an artery, a kind of ballooning out of the blood vessel wall. Think of a weak spot in a garden hose. That starts to bulge outward under pressure. That's essentially what's happening in an aneurysm. And just like with that garden hose, if the pressure gets too high, that weakened section can burst.
That's a terrifying thought. And you mentioned that we'd be focusing on abdominal aortic aneurysms or AAAs. Why are those the most common type?
The aorta, that main artery leaving the heart, runs through both the chest and the abdomen. For reasons that aren't fully understood, aneurysms are more likely to develop in the abdominal portion of the aorta below the diaphragm. And because the aorta is such a large vessel carrying a high volume of blood, a rupture in this area can be catastrophic.
Okay, that explains why they're so worrisome. And you mentioned different types of aneurysms. What are those?
There are two main shapes. Fusiform aneurysms, where the entire circumference of the aorta dilates uniformly, like a stretched-out tube. And saccular aneurysms, which look like a pouch or sac protruding from one side of the artery, like a balloon on a string.
Okay, so one's like a uniform bulge, and the other's more like a distinct outpouching.
Got it. And what causes these weak spots to develop in the first place?
Atherosclerosis, that same buildup of plaque we talked about with chronic arterial ischemia, is a major culprit. But other factors can increase your risk too, including high blood pressure, smoking, trauma to the area, and even certain genetic conditions. Sometimes it's a combination of nature and nurture, and sometimes it's just plain bad luck. So it's one of those conditions that can sneak up on you. But here's the question that's haunting me. How would I even know W if I had an aneurysm?
That's the tricky part. Many aneurysms are asymptomatic, meaning they don't cause any noticeable symptoms, and are often discovered, incidentally, during imaging tests for something else entirely.
So you could be walking around with this ticking time bomb in your abdomen and not even know it. That's scary.
Unfortunately, it's true in many cases, but there are some potential signs to be aware of. Some people experience a sense of fullness, or a deep throbbing pain in the abdomen that might radiate to the back. If the aneurysm starts to expand rapidly or is about to rupture resh, the pain can intensify, becoming severe and sharp, and it might spread to the groin, buttocks, or legs.
Okay, so sudden intense abdominal pain is a definite red flag.
Yeah.
What about during a physical exam? Can a doctor feel an aneurysm?
Sometimes, yes. A doctor might be able to feel a pulsatile mass in the abdomen during a routine exam, which would definitely raise suspicion. They might also hear a bruit, a kind of whooshing sound, over the aneurysm when listening with a stethoscope.
So regular checkups are important, even if you're feeling fine. Are there any specific screening recommendations for aneurysms?
Absolutely. Current guidelines recommend that men aged 65 to 75 who have ever smoked should have all one-time screening for AAA using an ultrasound. It's a simple, painless test that can detect aneurysms early on when they're most treatable.
That's actionable advice for our listeners, men in that age group, especially if you've ever smoked. Talk to your doctor about getting screened. Now, what about aneurysms in other parts of the body? We've been focused on abdominal aortic aneurysms, but can they occur in other arteries as well?
Yes, they can. Aneurysms can form in any artery, but they're most common in the aorta. Another location we sometimes see them is in the thoracic aorta, the part of the aorta that runs through the chest.
Thoracic aortic aneurysms, those sound even more terrifying being so close to the heart and lungs.
They can certainly be serious, but thankfully, they're less common than AAAs. Symptoms can range from being completely silent to causing chest pain, back pain, hoarseness, or even difficulty swallowing if the aneurysm presses on nearby structures.
So a change in your voice or difficulty swallowing could actually be a sign of a life-threatening condition.
It's a possibility, especially if it's accompanied by other symptoms, like chest pain or back pain. That's why it's crucial to never ignore sudden, unexplained changes in your body, and always seek medical advice if you're concerned.
That's sage advice. Now, we've talked about aneurysms, those bulges in the artery wall, but I've also heard the term aortic dissection. Is that related to aneurysms?
Aortic dissection is a related but distinct condition that requires urgent attention.
Okay, I'm intrigued. Tell me more about this aortic dissection. What exactly is it?
Imagine the aorta as a layered tube, kind of like a sturdy pipe with multiple layers. In an aortic dissection, a tear occurs in the innermost layer of this tube, the intima, allowing blood to flow between the layers of the aortic wall. It's like a crack in the foundation of a building, creating a weak spot that can easily worsen.
So the blood is basically creating its own detour, but in a very dangerous way.
Exactly. The force of blood flowing into this false channel can weaken the aortic wall, increasing the risk of a catastrophic rupture. It's like a ticking time bomb.
And what causes this tear to happen in the first place?
Uncontrolled high blood pressure is the biggest risk factor, accounting for about 70% of cases. But other things can contribute too, including cocaine use, connective tissue disorders like Marfan syndrome, and even trauma to the chest.
So yet another reason to keep that blood pressure under control. And how would someone know if they were experiencing an aortic dissection? What does it feel like?
The classic symptom is sudden severe pain, often described as tearing or stabbing, in the chest, back, or abdomen. Think of it like the worst pain you've ever felt coming on out of the blue.
Okay, that definitely sounds alarming. Is there any way to distinguish between the pain of an aortic dissection and, say,
Yeah.
a heart attack?
The location of the pain can sometimes provide clues. Pain in the front of the chest is more suggestive of a dissection involving the ascending aorta closer to the heart, which is classified as type A. Pain in the back between the shoulder blades points to a dissection in the descending aorta further down, which is type B.
Okay, so it's almost like a map of pain, guiding you to the location of the problem.
In a way, yes. And that distinction is important because type A dissections are generally more serious and require immediate surgical intervention. They're more likely to cause complications, like a heart attack or cardiac tamponade, which is a life-threatening condition, where blood fills the sac surrounding the heart, preventing it from pumping effectively.
Wow, that sounds terrifying. What about type B dissections? Are they less dangerous?
Type B dissections are typically managed medically, with medications to lower blood pressure and heart rate, but surgery might be necessary if there's evidence of organ damage, uncontrolled pain or blood pressure, or if the dissection continues to worsen.
So regardless of the type, prompt diagnosis and treatment are essential. But I imagine diagnosing an aortic dissection can be tricky. It sounds like it could easily be mistaken for other conditions, like a heart attack.
You're right. Aortic dissection is often a chameleon, mimicking the symptoms of other conditions. That's why doctors rely on a combination of tests, including chest x-rays, echocardiograms, and CT scans or MRIs to make the right diagnosis. The key is to rule out other possible causes of chest pain and ensure the patient receives the right treatment as quickly as possible.
It sounds like a real medical mystery. Now, shifting gears a bit, I know we need to talk about diabetic foot, which I've heard is a major concern for people with diabetes.
Diabetic foot is indeed a complex and multifaceted challenge that can have devastating consequences if not addressed properly.
Okay, let's dive into that then. What makes diabetic foot such a serious problem?
Diabetic foot is like a perfect storm, where several problems converge to create a serious health threat. It often stems from a combination of poor circulation, nerve damage, and a vulnerability to infections.
It sounds like a recipe for disaster. So walk me through it. What's going on in the diabetic foot that makes it so vulnerable?
Well, first you have ischemia, that reduced blood flow we've been talking about. Diabetes can damage blood vessels, especially those tiny capillaries in the feet, making it harder for blood to reach the tissues.
So it's like those tiny delivery trucks we talked about earlier are struggling to navigate those narrow, damaged roads.
That's a great way to think about it. And then to make matters worse, there's neuropathy, which is damage to the nerves.
Neuropathy, I've heard that term before. Remind me what exactly it does.
Diabetic neuropathy is like a communication breakdown in the nervous system. It can affect both the nerves that carry signals from the brain to the muscles, as well as the nerves that carry sensory information back to the brain. And it often starts with sensory neuropathy, a gradual loss of sensation in the feet. That spreads in a glove and stocking pattern, starting in the toes and working its way up.
So it's like the body's alarm system is malfunctioning, starting at the furthest points from the control center.
Exactly. And this is dangerous because you might not feel cuts, blisters, or other injuries on your feet. You might continue walking on an injured foot, making the problem worse, without even realizing it.
That's scary. I'm trying to imagine what that would feel like. Is there a way to test for sensory neuropathy, even before it gets to that point?
There is a subtle but significant early sign of sensory neuropathy is a loss of vibration sense. Doctors use a tuning fork to test this, but you can even try it at home. Grab a vibrating object like an electric toothbrush and see if you can feel the vibrations equally well on both feet. If one foot feels numb or the sensation is weaker, it could be an early warning sign.
That's a great tip. I'm definitely going to try that later. What other types of neuropathy are there?
There's also motor neuropathy, which affects the muscles in the feet leading to weakness, and deformities like clawfoot where the toes curl up. This can create pressure points and make the foot more prone to ulcers. And then there's autonomic neuropathy, which can disrupt the function of your sweat glands.
Sweat glands. I wouldn't have thought that sweat would have anything to do with foot problems.
You might be surprised. Sweat helps keep the skin moist and pliable. Without it, the skin on the feet can become dry and cracked, making it more susceptible to injuries and infections.
So it's like the skin's natural defenses are compromised, creating an entry point for bacteria.
Exactly. And that brings us to the third piece of the puzzle: infection.
Okay, so we have poor circulation nerve damage, and now the added threat of infection. Let's talk about those diabetic foot ulcers.
Sure.
What do they look like? And how do they differ from the ischemic ulcers you mentioned earlier?
That's a key distinction to understand. Neuropathic ulcers, the ones stemming from nerve damage, are often painless, which is part of the problem. They may have sloping borders and callus formation around the edges. Ischemic ulcers, on the other hand, are incredibly painful and have that punched-out appearance with a necrotic base.
So one is a silent danger, and the other screams for attention. It seems like that painless aspect of neuropathic ulcers makes them even more dangerous, because you might not notice them until they're quite serious.
That's right. And that's why regular foot inspections are so important for people with diabetes. Now let's talk about those infections themselves. What are some of the common culprits?
Yes, let's unpack that.
Diabetic foot infections are often polymicrobial, meaning they involve a mix of different bacteria. Staphylococcus aureus is a frequent offender, especially in cases of osteomyelitis, an infection of the bone. You can also see fungal infections like tinea pedis, better known as athlete's foot, and even in the most serious cases, necrotizing fasciitis, a rapidly spreading infection that can destroy soft tissue.
Necrotizing fasciitis, that sounds terrifying.
It is a very serious condition that requires aggressive treatment. But here's the good news. With proper foot care and attention to those early warning signs, many of these complications can be prevented.
Okay, so prevention is key. What are some specific things people with diabetes can do at home to protect their feet?
Daily foot inspection is paramount. Check your feet for any cuts, blisters, redness, or swelling. If you can't see, well, ask someone to help you.
It's like adding foot selfie to your daily checklist.
Exactly. And moisturize your feet every day. But avoid putting lotion between the toes, as that can create a breeding ground for fungus. Always wear shoes and socks, even indoors, to protect your feet from injuries. And of course, managing your blood sugar levels is crucial to slow the progression of nerve and blood vessel damage.
All good advice. Now, what about treatment options? How are these different aspects of diabetic foot managed once they develop?
It's a multifaceted approach.
Yeah.
If there's significant ischemia, revascularization procedures might be needed to restore blood flow. For neuropathic ulcers, treatment often involves debridement to remove dead tissue and specialized dressings to promote healing. Infections are treated with antibiotics, sometimes intravenously. And in severe cases, surgery might be necessary to drain abscesses or remove infected tissue. We also specialize offloading shoes that can help reduce pressure on those vulnerable areas of the foot.
So it's about supporting the body's natural healing processes while addressing the underlying causes.
Fascinating. Now let's shift gears and talk about the other side of the circulatory system, the veins. We focused a lot on arteries, but veins play a crucial role too, and they come with their own set of challenges.
Right. Veins are like the return route in our circulatory highway system, carrying blood back to the heart.
Okay, remind me, how is that return trip different from the outbound journey through the arteries?
Well, arteries have the force of the heartbeat, propelling blood forward, but veins have to rely on other mechanisms to keep blood flowing in the right direction. Think of it like this. Arteries are like high-pressure pipelines, while veins are more like a leisurely river system.
I'm picturing a lazy river ride versus being propelled down a water slide. That's a fun way to visualize it. Veins have one-way valves that prevent backflow, kind of like little gates that ensure the blood keeps moving toward the heart. And they also get a boost from the contraction of surrounding muscles, especially the calf muscles, which act like a pump, squeezing the blood upward. Even breathing helps, as the negative pressure in the chest during inhalation draws blood upward.
So it's a more collaborative effort with muscles and breathing assisting the veins in their task.
Exactly. But when this delicate system is disrupted, problems can arise. And that's when we start seeing conditions like chronic venous insufficiency, a broad term that encompasses a range of disorders affecting those lacy river veins.
And the most well-known example of chronic venous insufficiency is varicose veins, those twisted, bulging veins we often see in the legs.
You got it. Varicose veins are those dilated rope-like veins that often appear in the legs, particularly the calves and ankles.
I've always thought of them as a cosmetic issue, but I know there's more to it than that.
You're right. While many people see treatment for varicose veins for cosmetic reasons, they can also cause symptoms like pain, aching, heaviness, and even swelling in the legs. And in some cases, they can lead to more serious complications.
So they're not always just a harmless nuisance. What causes these veins to lose their shape and become varicose?
Sometimes it's simply a matter of genetics. Some people are predisposed to weaker vein walls or valves that don't close properly. But other factors play a role too. Age is a big one. Varicose veins become more common as we get older, as those vein walls lose their elasticity. Long-standing pregnancy, obesity, and even a history of blood clots in the deep veins can also contribute.
So it's a mix of nature and nurture, and some occupations that require a lot of standing, like nurses or hairdressers, might increase the risk. Besides the cosmetic concerns, what other problems can varicose veins cause?
One issue we see is superficial thrombophlebitis. It's basically a blood clot forming in a superficial vein, close to the surface of the skin.
Oh, so it's a type of DVT, but in a more superficial vein.
Exactly. It causes pain, redness, and tenderness along the affected vein, which will feel like a hard cord under the skin.
That doesn't sound fun.
It can be uncomfortable. But the good news is that superficial thrombophlebitis is usually a benign, self-limiting condition. It tends to resolve on its own with conservative treatments, like warm compresses and pain relievers.
Okay, so it's usually more of a nuisance than a serious threat. Are there other skin-related complications that can stem from chronic venous insufficiency?
Yes, one we see is lipodermatosclerosis, also known as stasis dermatitis. It's a type of eczema that develops in the lower legs. Due to chronic venous insufficiency, it can cause discoloration, itching, and thickening of the skin in the affected area.
So it's a rash, but
Yeah.
with a deeper underlying cause.
Exactly. And in more severe cases of chronic venous insufficiency, we can see venous ulcers. These are open sores that form on the legs, usually around the ankles.
And how do those venous ulcers differ from the ischemic ulcers we talked about earlier?
Venous ulcers are typically larger and shallower than ischemic ulcers, and they tend to have irregular borders, almost like a puddle spreading out. They're often less painful than ischemic ulcers, but they can be quite debilitating and slow to heal.
It seems like these chronic venous problems create a vicious cycle. The poor circulation makes the skin more vulnerable, leading to ulcers, and then those ulcers are slow to heal because of the underlying circulation problems.
You get it. It's a complex interplay of factors.
So how are all these venous problems diagnosed and managed? What tools do doctors use to assess those lazy river veins?
One of our key tools is duplex ultrasound. It's a type of ultrasound that allows us to visualize blood flow in the veins and check for clots or problems with those one-way valves.
So it's like a sonar for the veins, helping doctors see what's happening beneath the surface.
Exactly. And when it comes to treatment, the options range from simple lifestyle modifications to more invasive procedures, depending on the severity of the problem.
Okay, let's break those down. What are some of those lifestyle changes that can help manage venous insufficiency?
Some simple things you can do at home include avoiding prolonged standing, elevating your legs whenever possible, and wearing compression stockings to help support those veins, and improve blood flow.
So it's all about giving those veins a little extra support to help them do their job.
That's the idea. And for more troublesome varicose veins, we have minimally invasive procedures like sclerotherapy, where a solution is injected into the vein to collapse it, or endovenous laser ablation, which uses laser energy to seal off the vein.
So those are options for closing off those problematic veins altogether.
Right. And for venous ulcers, the focus is on compression therapy, specialized dressings that promote healing, and meticulous wound care.
Okay, so it's a multi-pronged approach, addressing both the underlying circulation problems and the resulting ulcers.
Precisely. Now, shifting gears a bit, we need to talk about a condition that often lurks silently, and it's one that strikes fear in the hearts of many: deep vein thrombosis.
DVT. It's definitely a condition I've heard a lot about, and I know it can be serious. What exactly is DVT and why is it so dangerous?
DVT is basically a blood clot that forms in a deep vein, usually in the legs. Think of it like a blockage forming in one of those deeper channels of our circulatory river system.
Okay, and why is that so dangerous? What makes a clot in a deep vein so much more worrisome than, say, a superficial clot?
The real danger lies in the possibility of that clot breaking free and traveling through the bloodstream. If it reaches the lungs, it can cause a pulmonary embolism, or PE, which can be life-threatening.
Okay, that explains the fear factor. So it's not just about the clot itself, it's about the potential for it to migrate and cause problems elsewhere.
Exactly. And unfortunately, many cases of DVT are asymptomatic, meaning they don't cause any noticeable symptoms until a complication like pulmonary embolism occurs.
So you could have a clot lurking in your leg and not even know it. That's scary. What causes these clots to form in the first place? Are some people more prone to them than others?
There's a classic trio of risk factors, known as Virchow's triad, that we look for when assessing DVT risk.
Virchow's triad. It sounds like a secret society of clot-forming villains. Tell me more about this triad.
The first villain is venous stasis, which simply means slow or stagnant blood flow in the veins. Think of those lazy rivers becoming even more sluggish.
So like a traffic jam in the veins.
Exactly. This can happen from prolonged immobility, like being bedridden after surgery or during a long flight, or even just sitting for extended periods without moving your legs.
So get up and move around, people. What's the second risk factor in this triad?
The second villain is endothelial injury, which means damage to the lining of the blood vessels. It's like a scratch on the inside of those pipes, creating a rough spot where clots can easily form.
Okay, so it creates a snag where those clotting factors can latch on and start building up.
Precisely. And this type of damage can occur from trauma surgery, or even certain medical conditions like atherosclerosis, which, as we discussed, can roughen up those arterial walls.
And the third piece of the triad?
The third villain is hypercoagulability, which simply means that your blood is more likely to clot than usual.
So it's like your blood is extra sticky, ready to clump together at the slightest provocation.
That's a good way to think about it. Hypercoagulability can be caused by inherited clotting disorders, certain medications like birth control pills or hormone replacement therapy, pregnancy, or even cancer.
So it's a combination of sluggish blood flow, damage to the veins, and a predisposition to clotting. Definitely not a good mix. Now let's talk about those warning signs. What are some red flags that might signal a DVT?
The most common symptom is swelling in one leg, usually accompanied by pain, tenderness, and warmth in the affected area. However, as we mentioned, many cases of DVT are asymptomatic, meaning they don't cause any noticeable symptoms until a complication occurs.
So you may not even know you have a DVT until it's too late. That's scary. How do doctors diagnose this silent threat?
We use a combination of tests, including a blood test called a D-dimer and ultrasound imaging. The D-dimer test measures a substance that's released into the blood when a clot breaks down, so elevated levels can indicate the presence of a clot. And ultrasound allows us to directly visualize the veins and look for signs of blockage.
Okay, so those tests can help unveil those hidden clots. And what about treatment? How is DVT managed once it's diagnosed?
The mainstay of treatment is anticoagulation, which essentially means thinning the blood to prevent further clot formation. We use medications like heparin or warfarin to achieve this.
So it's like putting a stop sign in front of that clotting cascade.
Exactly. And in some cases, we might recommend an IVC filter, which is a small device implanted in the inferior vena cava, the large vein that carries blood back to the heart.
Okay, and what does this filter do?
It acts like a safety net, catching any clots that might break loose and travel to the lungs. It's not a first-line treatment, but it can be helpful for patients who have contraindications to anticoagulation or who have had recurrent clots despite medication.
So it's like an extra layer of protection for those high-risk patients. Now, I know we're focusing on treatment, but I'm also curious about prevention. What can people do to lower their risk of developing DVT in the first place?
That's a great question. If you're having surgery, talk to your doctor about preventive measures. There are things like compression stockings, which help squeeze those leg veins and keep blood moving, and pneumatic compression devices, which intermittently inflate and deflate to mimic the pumping action of the calf muscles.
Boo.
And in some cases, your doctor might recommend medications to prevent clotting.
So it sounds like there are several strategies that can be employed depending on the individual's risk factors. What about general lifestyle recommendations for DVT prevention?
Staying active is key. Avoid prolonged sitting and get up and move around every hour or so. If you have a job that requires you to sit for long periods, maintaining a healthy weight and staying hydrated are also important.
All good advice. Now, before we wrap up our journey through the vascular system, there's one more condition I want to touch on, lymphedema. What is it, and how does it relate to all these other vascular conditions we've been discussing?
Lymphedema is a condition characterized by swelling, usually in the arms or legs, due to a buildup of lymph fluid. It's a bit different from the other conditions we've discussed because it involves the lymphatic system, which is a separate but interconnected network of vessels and nodes.
Okay, so it's like a parallel system running alongside our circulatory system. What exactly does this lymphatic system do?
It plays a crucial role in immune function and fluid balance. Think of it as the body's drainage system, collecting excess fluid and waste products from the tissues and transporting them back to the bloodstream. It also helps fight off infections by filtering out harmful substances and harboring immune cells.
So it's like a combination of garbage disposal and a security system for the body.
That's a great analogy. Now, lymphedema occurs when this drainage system is disrupted, causing lymph fluid to accumulate in the tissues, leading to swelling.
I see. So it's like those drainage pipes getting clogged, causing a backup of fluid in the tissues. And you mentioned that lymphedema can be either primary or secondary. What's the difference between those two types?
Primary lymphedema is caused by a congenital abnormality in the lymphatic system, meaning it's present from birth. It's relatively rare. Secondary lymphedema, on the other hand, is much more common and occurs as a result of damage to the lymphatic system.
Okay, and what are some of the things that can damage the lymphatic system?
One of the most common causes is cancer treatment, specifically surgery or radiation therapy involving lymph nodes. For example, women who have undergone axillary lymph node dissection for breast cancer are at increased risk of developing lymphedema in the arm.
So it's like collateral damage from the cancer treatment,
Yeah,
affecting this delicate drainage system.
exactly. Other causes of secondary lymphedema include infections, trauma, and even certain medications.
And I imagine lymphedema can be quite debilitating, both physically and emotionally, especially for those who develop it as a consequence of cancer treatment.
Absolutely. It can be a frustrating and challenging condition to live with. The swelling can be uncomfortable and make it difficult to move the affected limb. It can also lead to skin changes, infections, and even psychological distress.
So it's not just about the physical symptoms, it's about the impact on a person's overall quality of life.
That's right. And treatment focuses on managing those symptoms, reducing the swelling and preventing complications like infections.
Okay, so what are some of the treatment options for lymphedema?
There's no cure for lymphedema, but there are effective ways to manage it. Compression therapy is a cornerstone of treatment. We use specialized bandages or garments to help squeeze that excess fluid out of the tissues.
So it's like giving those lymphatic vessels a helping hand, providing external support to improve drainage.
Exactly. And exercise can also be beneficial, as muscle contractions help pump lymph fluid back towards the heart.
So it's another example of how movement and exercise are crucial for maintaining a healthy circulatory system.
Absolutely. And there's a specialized touch massage called manual lymphatic drainage, which can be helpful in reducing swelling. It's a gentle technique that helps stimulate the flow of lymph fluid.
So it's like a hands-on approach to unclogging those lymphatic pathways.
Precisely. And of course, for secondary lymphedema, treating the underlying cause is essential. So if the lymphedema is caused by an infection, treating that infection will be crucial.
Okay, so it's all about addressing both the symptoms and the root cause of the problem. We've covered a lot of ground today, from those high-pressure arterial highways to the more leisurely venous rivers and the intricate lymphatic drainage system. It's amazing to think about all these systems working together to keep our bodies functioning properly.
It is an amazing and complex system. And we haven't even touched upon all the intricacies.
I know, we could probably spend hours talking about the vascular system, and we still wouldn't scratch the surface.
That's true. But I think we've covered some key points that will help our listener better understand their own vascular health.
Absolutely. Before we wrap things up, is there anything that particularly stood out to you during this deep dive? Anything that surprised you? Or that you think our listeners should pay extra attention to?
For me, it's the emphasis on prevention and early detection. We've talked about so many conditions that can be prevented or managed more effectively if they're caught early. Those simple lifestyle modifications like quitting smoking, exercising regularly, and managing blood pressure and cholesterol can truly make a difference in your vascular health.
Absolutely. And knowing the warning signs, those subtle clues that something might be amiss, can empower you to seek medical attention sooner rather than later.
Right. It's all about being proactive and taking ownership of your health. It's like having a roadmap and a toolkit for navigating your vascular system.
I love that analogy. We've equipped you with the knowledge to recognize potential roadblocks and detours, and hopefully you now feel empowered to take those preventative measures and seek help when needed.
Exactly. And remember, even if you don't have any of the risk factors we've discussed, regular checkups with your doctor are still crucial. They can assess your overall health, catch problems early, and provide personalized guidance based on your individual needs and circumstances.
That's so important. Don't underestimate the power of those routine visits. Sometimes a simple observation or a quick test can make all the difference.
It's true. Doctors are like those skilled mechanics who can spot subtle problems before they become major breakdowns.
Now, as we wrap up our exploration of vascular surgery, I am left wondering about the future of this field. With all the advances in technology and our growing understanding of the human body, what do you think the future holds for vascular health?
That's a great question. I think we'll continue to see a shift toward less invasive procedures, minimizing the trauma and recovery time for patients. We're also making strides in targeted therapies, using medications and treatments that are specifically designed to address the underlying causes of vascular diseases. And I think personalized medicine, tailoring treatments to the individual patient's genetic makeup, and lifestyle factors will play an increasingly important role in vascular health.
It sounds like a future filled with precision and personalization, moving away from those one-size-fits-all approaches.
Exactly. It's an exciting time to be in this field, and I'm optimistic about the advancements we'll see in the years to come.
I'm excited to see what those advancements are. Well, I think we've successfully navigated the complex and fascinating world of vascular surgery. We've explored the highways and backroads of our circulatory system, learning about those potential roadblocks, detours, and even those silent threats that can lurk beneath the surface.
We've certainly covered a lot of ground, and hopefully our listener feels empowered to take charge of their vascular health, armed with the knowledge and tools to make informed decisions and seek help when needed.
Exactly. It's always a pleasure to delve into these fascinating medical topics with you. And to our listener, thank you for joining us on this deep dive. We hope you've gained valuable insights and perhaps even discovered a few aha moments along the way. Until next time, keep learning, keep exploring, and keep diving deep.